Last module on layperson empowerment in heart failure, where we're going to explore certain information that we should be passing on to our laypersons in order to help them cope better with heart failure. With this slide, I want to stress the importance of the role of the pharmacist in HFrEF education. One of the things that we should routinely be telling our patients about is really the disease-modifying roles of the medications. And we've been talking about the Fantastic Four, and I hope by now it's ingrained in your brain. And essentially, the onset and the adverse drug reactions are critically important when you offer medicines upfront. And I want to tell you a story about this patient. I used to have a cheeky man who was on both the ACE inhibitors, the spironolactone, as well as beta blockers. And in those days, we didn't have so many other agents yet at the time. So typically, this man, when he went to get his medicines from the dispensary, right, the people who dispensed to him, of course, told him they are for blood pressure, because clearly they wouldn't have known that he had heart failure. So he very cheekily told me, oh, you know, I since the pharmacy told me that it's for blood pressure lowering, right, I just decided to take A on day 1, B on day 2, and then C on day 3. And I was like, what? That actually experience taught me to stress to the patients the importance of all the agents used in combination. Now, sometimes the patients, when you dispense to them or you talk to them about the medications, right, you assume that they know and they understand. But it's critically important to tell them that the combination is very important. And all of them used together will act towards disease modifying and reduce mortality for people with heart failure. Now, you might struggle with telling them about reduced mortality. So what I usually tell them is if we do not use any of these medications, at the end of 1 year, about 20% to 50% of all the heart failure patients will no longer be in existence, or they will pass away. So a lot of these medicines that we're using today is to reduce that risk of you passing away at the end of the first year, and give you a long and healthy life, also to take away the symptoms of heart failure and make you feel better. The other thing that's worthwhile mentioning is the onset of beta blockers is quite slow. Sometimes it takes up to 2 weeks to even a couple of months before people feel better after being started on beta blockers. So we also have to tell our patients to be patient and not be too, not have too high expectations of getting back to their usual states so quickly. It's important to also clearly communicate how and when to follow up and what blood tests you want them to also do, because it's critically important for them to understand that sometimes the blood tests are repeated for their own good and to monitor for any sort of adverse drug reaction, rather than let them be worried that we are drawing blood all the time, or say that they're losing too much blood towards appointments or coming back too frequently. It's always important to tell them upfront that all these medicines will generally require titration. So whenever I meet a new heart failure patient, I will tell them, oh, you know, Mr. So-and-so, because of your situation with a weak heart, I'm here to optimize your use of medicines and to adjust the doses such that you get the best out of your heart failure medicines. Now, in the start, I may have to see you very frequently, sometimes as frequently as every 2 weeks, depending on how stable or how well you are and how many of your medicines I will adjust. Now, this is something that happens in the first couple of months, but when you are more stable, we can actually space out your appointments, and then all your medicines, when they have optimized, right, you already get the best value out of them. You will not need to see me so often. And I often joke that, oh, now that I see you so often, next time you want to see me, I also don't want to see you already. And that usually builds rapport with the patient as well. I also critically tell them about the weight increase overnight, and that's something that we want them to take their body weights every day. So what we tell them to do is, when they wake up in the morning, they should go and void their bladders and then weigh themselves, preferably in the same set of clothing every morning. Try not to vary too much, because, you know, like for example, jeans or some other heavy material can cause quite a lot of fluctuation in the body weight. And if they think to themselves they put on 2 kilos, they might just panic unnecessarily, when it's actually really the clothing and the keys and the wallets that are in their pockets. I put a picture of both the analog as well as the digital body weight machine there. I just wanted to say that for some, they have difficulty reading the dial on the analog weighing machine. And so of late, with the digital machines, it's a lot easier for even the illiterate patients to take their own body weight. I remember I had one patient who had difficulty reading the dial, and so we made him buy the body weight, this weighing machine from Watson's, and I remember it was like about $10-20 only. Whenever he came to clinic, right, he didn't even know how to write the decimal place for me. He would document the 3 digits that he saw, and I was able to use the 3 digits to monitor whether he has actually put on weight or not, and whether his weight has been stable in the time that I've not seen him and he's spending with himself. So the digital weighing machines have been proven to be quite useful. The other thing is the size of the receptacle that they use. Now, we keep talking about fluid restriction, right? We assume that our patients understand that concept. Now, remember, a lot of our patients have not gone to school, or maybe they have, but they are unable to link the concept of receptacle size with the amount of fluid that they need to drink or avoid a day. So the use of these bottles, like the mineral water bottle, you tell them this is 500 mils, they can drink this much per day. Sometimes I tell them to use a 1.2 liter bottle and fill it up for that day, and that's their quota for the day. And essentially, if they drink extra soups or coffees or teas, they are to take out the same amount from that bottle and pour that away, just so that they don't exceed the 1.2 liters per day of fluid intake. Remember to stress to them that it's fluid intake that we're talking about, not just water, because the idea of water is actually wrong, right? Because you're talking about the total fluid intake. Now, on the reverse side of things, some of these patients are so scared about the fluid overload, right, that they go home and they don't drink any water at all, and that's actually not good for the body. This can also result in an AKI situation, like when the serum creatinine rises very quickly and suddenly, and therefore they go into a state of acute kidney injury. So it's also important to stress to them that while we want them to restrict fluid intake, especially in the acute part when they were unwell, we also need them to drink enough water per day, because that's also the balance they want to strike. And lastly, the sodium intake is particularly important for heart failure patients, because when they are in fluid overloaded states, the water retention will follow the sodium retention. So if they take a lot of sodium, on the contrary, for heart failure, this is something that I'll be fixating about. I think this is important, particularly when they have been readmitted several times for fluid overload, or they're not responding to their loop diuretics well. That's when you need to tell them to be very careful about the sodium intake. And I stress again, is sodium intake and not salt intake, because anything that contains sodium can also count towards the sodium load per day. And I just want to remind everyone once again, as we talked about salt substitution, some of your more well-educated patients may be using salt substitutions which actually contain potassium. So if you recall, with the RASI agents, a lot of them cause potassium retention in the body, and so if they were to use salt substitution, they have to make sure that the healthcare professional or so that in case when you repeat the potassium, when you monitor them, the potassium goes high, you can try to investigate for the causes of high potassium, and if needed, also to downregulate the use of salt substitutes. This is a chart that we use for heart failure patients at the Khoo Teck Hospital Pharmacy run clinic. And essentially this chart charts for you throughout the whole year. Please do not panic if the patients start to put on weight slowly, and that's expected, right? Because you're supposed to lose 0.5 to 1 kilo a week, right? You should, if you ever put on weight, eat more, then of course you'll be putting on weight slowly, like 0.5 to 1 kilo a week. So this is useful for you to see the waxes and wanes in the blood pressure, the body weight. And so it's critically important to tell them that the routine that they must follow every morning. They empty their bladder and then they go and take their body weight before their breakfast, because sometimes, you can drink as much fluid as 1 liter to 2 liters, and that can already cause you to gain 1 to 2 kilos of body weight. Okay, so we want them to record their body weights on this chart, just so that every time they come back to the clinic, right, you can have a look at their body weights to see whether they have been accumulating fluids or not. And this also shows as a visual cue to them, right, to monitor themselves. And if there's a sudden weight gain, they know that they can look for help or attention. So I encourage my patients who are not so well educated to call me, and then I will teach them how to dose loop diuretics over the phone, how to increase loop diuretics over the phone. For some who are a bit more well educated and are empowered to do these things, you can allow them to increase their loop diuretics themselves. Of course, if it happens too frequently, you need to tell them to bring forward an appointment so that they can be assessed, as well as blood tests can be repeated so that they're not exceedingly using diuretics and losing too much potassium from their blood as well. I like this wheel because it's very well organized in terms of the process for patient care for HFrEF, and this is particularly important if you were going to be trained to take care of heart failure patients in the clinic in the longer term future. So what you do to collect information, you look at the patient's characteristics, and this is how we are trained, right, for the social and history taking, right? You guys have done all this so far. Look at the medical history, social history, current medications, including OTC, supplements, any sort of intolerances from before, and allergies to any sort of substances or medications. And then look at the objective data, including blood pressure, heart rate, respiratory rate, height, weight, left ventricular ejection fraction, etc., to work up the patient well. Any sort of lab tests also constitute as objective information. And any sort of physical examination, like if you looked at the ankles and you pressed in and you get pitting edema, that is a sign of fluid overload. And just to remind everyone what are the signs and symptoms of fluid overload is I put this picture over here, and you can go back to this picture in the earlier slides to refer to the symptoms that heart failure patients typically have. Then you assess the patients with respect to hemodynamic stability, look at whether their blood pressures are stable, whether the presence of comorbidities that may influence your choice of what medications you want to add or adjust or titrate. Whether there's a presence of fluid overload, then you might need to think about adding a loop diuretic or increasing the loop diuretic. And if they are symptomatic for heart failure, whether they're dyspneic, whether they have autopnea or fatigue, then you might need to up-titrate their medications further to improve their quality of life and exercise tolerance. Also look at the emotional status, and depression is not uncommon for heart failure as well, because I mean, you can imagine if you in the past could do so many more things, and then with heart failure you are now caged in and you can't do your usual activities as you did before. For plan, think about the pharmacotherapy, and we've talked about the Fantastic Four, the diuretics. If the patient is in fluid overload, think about additional drug therapy like ivabradine, digoxin, or hydralazine, ISDN as needed. Here, think about what you want to monitor as well for safety and efficacy, and that would determine when you want to bring the patient back, right? And what blood tests you want to order. Patient education, as we've gone into detail from before. And then lastly, think about referral to other professionals where appropriate. Lastly, when you want to implement any plans, remember to carry out all your patient education with all the elements of your treatment plan. Whatever you want to do for the patient, make sure that you tell them or give them written instructions for them to refer to, because it can be quite overwhelming, as you saw in the shared decision-making class. If you want patients to self-monitor at home, give them charts, the empty chart as you saw in the earlier slides, for daily body weights. And then for fluid intake also, give them a water bottle, or tell them to buy a water bottle, or use a mineral water bottle that's 1.2 liters, and then start to empty that throughout the day. That's one way to help them to identify how to best do it in terms of coping. Shared decision making is very important for you to talk through and offer all the therapies, tell them how important the therapies are in order to maximize adherence. Don't get in a situation like my other uncle from before, who says I take A one day, B one another day, and then C the next day. Also tell them about your follow-up, when to come back, and what tests you're going to be running, whether it's going to be electrolytes or serum creatinine, and what the vital signs and adherence assessments that you're going to do. Of course, the longer term plan is to ensure that they no longer have heart failure signs and symptoms anymore. And the presence of adverse effects should hopefully be absent. The patient adherence to treatment plan is also important for you to solicit the next time the patient comes back to see you in the clinic. All right, so I hope this wheel has nicely summarized what you need to do for heart failure patient for you. Actually, this same wheel can also be applied to any other conditions that you're managing. So this will become an important framework for all the pharmacotherapeutic conditions or considerations that you might have moving forward. All right, folks, you're now ready to head for the live class. Please read through the ESC 2021 Guidelines Supplementary Data document. There are a few supplements to tell you how to use the various agents that we commonly use in heart failure, especially the Fantastic Four. So read through that particular handout and prepare for the live class soon. See you then. Bye.